Just a few housekeeping points before we begin. This webinar is being recorded. Please mute your phone or laptop now and keep it muted during the presentation to prevent feedback and any distracting background noises. After the presentation, there will be an opportunity to answer your questions. If you wish to submit questions or to offer comments at any point during the presentation, you can use the chat box in the lower right-hand corner of your screen. The webinar will last no more than an hour in total, including questions, which will take place after the formal presentation. Please remain muted unless you wish to ask a question, and use the raise hand option to indicate you wish to speak. The recording will be made available both for your future reference and for the benefit of those who couldn't attend. This webinar is part of a set of activities to help innovative digital companies engage with the health and social care system across the north of England, and is being delivered through collaboration of the 4 Northern Academic Health Science Networks. Academic Health Science Networks, or AHSNs, have been set up to link researchers and innovators from academia and industry with health and social care providers and commissioners so that they can work in partnership to develop and adopt new products and services which can improve health outcomes for citizens and make health and social care provision more efficient and sustainable. Over the next year, we will be assisting the spread and adoption of innovations with proof of impact and value, and support our healthcare system to integrate these into practice at pace and scale. I'd now like to hand over to Samir Qatari, Chief Executive Director of Zilico, who will be delivering the formal presentation on ZScan.
Thank you, Paul. Good afternoon, ladies and gentlemen. First and foremost, and a real appreciation for all of you that have joined, and wish that you and friends and family are keeping well in what we find as an unprecedented situation for the UK and globally. My reading of the science and my understanding of the science is we will get through this, and it is the scientific breakthrough that will help us get through this. It is in this spirit that we host this afternoon's webinar, and our own science that has helped improve pathways in the cervical cancer space. So this afternoon, my colleague and I, Alison Roberts, will go through the clinical challenge around the cervical cancer pathway, how electrical impedance spectroscopy is helping that pathway, and then the all-important question around patient outcomes, and then how do we afford that within our mature healthcare systems. And then we're lucky enough to hear from clinicians within the Bradford Royal Infirmary and Burnley Hospital about their experience in using ZScan and adopting. And last but not least, there's an opportunity for us to all have a question and answer. We all today work within the healthcare spectrum, from prevention to social care. Over the years, there's been a lot of emphasis around therapy, and rightly so. But as we live longer and affordability of healthcare becomes a significant issue, the last 2 years, government ministers and public health bodies have been emphasizing the focus around prevention and diagnosis. And that is where Zilico sits in that diagnostic space. I'm now going to ask my colleague, Alison, to walk you through the clinical challenge that we find within the cervical cancer space. Over to you, Alison.
Thank you, Samir. Hello, everyone. Working as a qualified nurse colposcopist in the NHS for 17 years, I've acquired a great deal of experience of assessing and managing patients with pre-cancerous lesions of the cervix. Colposcopy equipment, the examination and technique has changed very little in the last 80 to 90 years. And colposcopy, we know, is quite a subjective art. It's very reliant on visual inspection and interpretation of skin reaction, to the application of a vinegar solution, which helps the clinician to identify and pinpoint abnormal cell changes on the cervix. This art of visual interpretation to accurately assess abnormalities is becoming increasingly challenging, I think, as these slide images show. The astute among you will see that the top images are of the oral cavity and actually not the cervix. And although I'm not a dentist, the oral cavity is covered by the same type of squamous epithelium or skin as the cervix, and thereby the same principles for diagnostic accuracy apply. As you can see, the top left image shows a marked white lesion to the floor of the mouth. Clinicians usually work on the principle that the whiter and more clearly defined the lesion, the more advanced the disease. However, this lesion did not progress to cancer. But looking at the less visible mouth lesion on the right, you can see it is smaller in size and much less prominent to the naked eye. This lesion did go on to progress to cancer within a relatively short period of time of about 10 months. Likewise, the images at the bottom of your screen, which are of the cervix, show a marked white lesion in the bottom left image around the birth canal, which most colposcopists would recognise as being a high-grade pre-cancer, requiring treatment to prevent disease progression. However, if you look at the image on the bottom right, the lesion is much less prominent, much milder in appearance, and is more suggestive of a low-grade abnormality. In reality, both lesions tested positive on biopsy for high-grade changes. Going forward, the introduction of primary HPV testing means that more patients will be referred to colposcopy at an earlier stage of their abnormal cell development and are likely to present with smaller, less visible lesions or no cervical abnormality at all. Challenges for myself and other colposcopists are complicated by the knowledge that not all high-grade lesions are reactive to the vinegar solutions applied to highlight cell changes, and those lesions can be missed on visual inspection. The difficulty of accuracy in colposcopic assessment and diagnosis is widely recognised and understood in the colposcopy community, both nationally and internationally. Our own NHS cervical screening programme recommends standards and KPIs for the maintenance of quality assurance within colposcopy services. Quite rightly, the bar is being raised for diagnostic accuracy, and there is increasing pressure for clinicians to meet these performance standards. In conclusion, the images shown here help to represent the present and future challenges myself and colposcopy colleagues, dentists and other clinicians face in achieving accurate assessment and diagnostic standards for treatment and prevention of invasive cancers. Thank you. I'll now hand you back over to Samir, who will tell us how this new technology is helping to overcome these challenges.
Thank you, Alison. Indeed, it was these challenges that was the genesis of Zilico. So a clinical colleague of Alison's, Professor John Tidy, who's a recognised key opinion leader within the cervical cancer space, was becoming more and more aware of the forthcoming challenges. And he shared this with a fellow professor of medical physics, Professor Brian Brown. Brian had spent his academic career looking at the electrical properties of organs, tissue and cells. Indeed, he'd actually worked with on the Mir space program ahead of Helen Sharman, first British person to go to moon, and was working with her to look at how changes in the body can be predicted and using the electrical properties. And indeed, he had his eureka moment when John was explaining the challenges within the cervical cancer pathway. And what we now know is as disease progresses from normal into early precancer, into late precancer, and then frank cancer, the electrical properties of cells and tissue changes. And using electrical impedance spectroscopy, you can measure that and then convert that into diagnostic information for the clinician to better manage that patient. EIS is a platform technology, as many of you will recognize, and we are using this and developing a pipeline of other products. So we've got a program of work under the oral cancer pathway. We've recently received a £1 million grant from the NHS under their SBRI program, and we're later this year going into a trial to bring that to fruition. Another area of interest has been around tissue margin during surgery. And we know clinicians want to remove as little as healthy tissue as possible, especially for important areas such as thyroid or the brain. And again, later this year, we're going to start some work with the Royal Marsden to progress this. This afternoon's focus is around Z-Scan, our flagship product within the cervical cancer pathway. And the development of this was done in collaboration with the NHS. And the benefit of that was really bringing a product that would have not only the efficacy, which is absolutely critical, but also utility, in the sense that you've got a busy hospital, you've got patients waiting outside, busy clinics, things need to work and go through and provide value in that sense. And you can see there the development pathway in terms of having what I call the middle picture there, the electronic toothbrush version, to what we now have is an ergonomically designed device that is suitable for gynecology clinics. We zoom into the picture, then you can see the device, and it has a base station or a docking station that connects through a USB cable into the NHS network to upload and download patient data. The device uses a single-use sensor, which is used to examine the patient in situ. So the EIS sensor on the left, the clinician would place that onto the device and then take between 10 and 12 readings of the transformation zone of the cervix. This takes no more than 2 minutes. The EIS technology is a non-optical technology, and so it works really well with the visualization that Alison was talking about that clinicians have relied on so heavily over the years. We're not taking that away, but working alongside that. The benefit of having an electrical technique is that the results are produced immediately. So at the end of the examination, the clinician has the data there in front of them and then can make a judgment on the best way to manage that patient. I've mentioned several times about efficacy and being absolutely critical in this area, and I've got a couple of slides on that coming through, so I'll cover that there. But as you can see, this is a device that is simple, easy to use, and it does seamlessly integrate into clinical practice and current clinical practice, so alongside colposcopes that are used for the magnification of the cervix. So coming to the efficacy, Alison very articulately mentioned about some of the challenges, and if you then put that into sort of figures, the accepted performance of colposcopy and the ability to accurately detect disease ranges anywhere from about 42 to 63. And if you look at Z-Scan, so Z-Scan's been through, as you would expect, a number of clinical trials that all have been published in peer-reviewed journals. When we're out there with your colleagues within the NHS, whilst the clinical trials are very important, what they really want to see is real-world data and saying, how does this work? And how does the efficacy work in a real-life situation? Sheffield, which is our key reference centre, we've worked alongside them to produce real-world data. So the table on the right-hand side is real-world data from a cohort of 1,500, just over 1,500 women. And in this cohort, the headlines were that overall Z-Scan managed to detect more disease, just under 14%. The area that is really important and becoming critical to clinicians is women who are referred with low-grade abnormalities. In that cohort alone, there was a 50% increase in high-grade disease detected. That is very significant, as all you will appreciate. In the area of colposcopy, random biopsies as a concept has been around for a few years. And so if you have a scattergun approach, you can find a lot more disease. But actually what we found in this real world data was that with Z-scan, which helps you more precisely and accurately take biopsies, there was a reduction in biopsies. That has clearly the benefit of reducing morbidity for patients, but also in terms of the workload within histology. The real attractive factor or parameter for colleagues within procurement and finance was the reduction in follow-up appointments. Sheffield, over the period of using this, using Z-scan, saw a 40% reduction in follow-up appointments. And that's all about efficiency and capacity and improving that capacity within the hospital, either to see more patients within colposcopy or actually direct resources towards perhaps vulvar disease, which has long waiting times. Again, Alison mentioned that we are moving into, or we have moved into this new paradigm of HPV, primary HPV screening. HPV test is a biomarker test, and it is a very sensitive test, a sensitivity of 99%. But like many biomarker tests, it falls down when it comes to specificity. So the specificity is a bit poor. So to clinicians like Alison and John, what's really important is knowing whether when a woman comes to colposcopy, there has been some abnormality in terms of the disease. Just knowing that they're HPV positive is not as useful. Sheffield was part of the Sentinel study prior to the introduction of primary HPV screening right across the country. And when the final presentation was made from the Sentinel study from six centres, one of the issues they found was that there was an 80% increase in women being referred into colposcopy, and that's a capacity issue. How do you better manage that capacity? What we have here in terms of the data, as you can see on the left-hand table and the right-hand table, is the impact Z-scan has made within Sheffield. So what we can look at more specifically on the left-hand table is that Z-scan improves the detection of high-grade disease. And you can see that 50% increase in the low-grade referral. Another benefit of Z-scan was within the see and treat cohort. The treatment at first visit is a common practice within colposcopy. And Sheffield had a rate of about 39% prior to Z-scan being introduced. During this study, their see and treat rates went up to 68%. Again, a significant increase, and it shows you the confidence the clinicians had in treating women at first visit. If you look at the right-hand table, this is now a different cohort, but this is just primary HPV screening cohort. And again, you can see similar, or I suppose more acute improvements with using Z-scan. So again, a significant increase in the detection of high-grade disease. And especially in the low-grade cohort, you can see that increase from, if we take the baseline at 50%, it moved up to 109%. Treatment at first visit also improved. And the biopsy rates were pretty similar during these studies. You won't be surprised to hear with all the clinical papers, the real-world data, that bodies, public health bodies such as NICE and Public Health England have become aware of Z-scan. So we had our first interaction with NICE back in 2014, and on the back of that they produced what's known as a MedTech Innovation Briefing Note in 2015. And that was really to raise the awareness of Z-scan amongst clinicians and wider across the NHS. In 2018, NICE issued some guidance notice, and that was based around the old screening, so sort of cytology, and not quite yet into the primary HPV, as we hadn't moved into that at that point. We expect Z-scan to be fully recommended in 2021. The image on the right is a reference to what Alison mentioned in terms of the KPIs within a quality assured program like the cervical cancer screening. And the target positive predictive value for clinicians to detect high-grade disease has now moved up 75 to 75%. And you'll see the relevance of that coming through in a minute. With all this data, what we're starting to see, and as clinics are now in primary HPV, is that there is a lot of interest for, with Z-scan. We have 9 centres that have adopted Z-scan, are routinely using the product in managing their cohort. We have a further 11 NHS trusts currently in procurement stage. We have 3 that are evaluating the product in their clinic, and a further 14 planned for evaluation in 2020. What we're going to do now is hear from Bradford Royal Infirmary.
My name is Nick Myers and I am the lead colposcopist for Bradford Teaching Hospitals. I've been working in the department here for 17 years. I've been in colposcopist for rather more than I care to think. And I also have outside wrestling involvement with the SCCP.
My name is Suzanne Taylor. I'm the lead nurse colposcopist here at Bradford Royal Infirmary and the cervical screening programme lead for the Trust. Here at Bradford Royal, we serve a diverse community of around 535,000 people. The community is quite mobile, and it's really important that when we come to colposcopy with an abnormal smear, that we get it right for the patient first time.
Advanced colposcopy courses, which is my involvement with the SCCP, I've attended a number. When we do case studies, there's a lot of debate and discussion when pictures go up of low-grade referrals and difficult to interpret pictures. The number of colposcopists who would immediately discharge, some would biopsy, some would want to follow up. And it's not because people don't really know what they're doing, it's because the diagnosis is difficult. And although colposcopy may be a simple examination, it's a skill and it can be difficult to get right. And something like Z-scan, as my reading of the evidence says, is shown to improve the accuracy of the process. So it's got to be better, it's got to allow better decision making. I think on a very simple basis, if there's an additional technology that can improve the accuracy and the efficiency of what we're doing, then it has a value. In many ways, it doesn't need another justification. I think in terms of colposcopy, we are all aware of a potential bulge in numbers coming, so we do need to optimise the process that we deliver in an individual clinic. But furthermore, because we know that colposcopy itself is not 100% accurate, anything that can improve the individual's performance must be valued precisely because it will be improving the performance of the whole screening programme. Finally, if the concerns that colposcopy itself may become more difficult as HPV 16 and 18 are less and less of a factor in driving CIN, when one accepts the argument that they provide the most obvious changes at colposcopy, then having Z-scan or an adjuvant technology is obviously important for the gynaecologist carrying out colposcopy or the nurse carrying out colposcopy, because it may help them overcome that particular difficulty.
Z-scan provides additional information following my colposcopy that will enable me to be confident that I have made the right diagnosis for the patient. Z-scan helps confirm the presence of high-grade disease if we're wanting to see and treat on the day, reducing the fear that we might be over-treating women, but also with low-grade and borderline SMEs, which can often be difficult to confirm presence of CIN. It helps detection certainly of high-grade lesions that may otherwise have dismissed. As a service, we're aware that with the introduction of primary HPV screening, that referrals are due to increase in the next 12 months. This could create capacity issues for our service and other services across the country. We need to be able to ascertain how we can manage these women more quickly and enable us to create to diagnose effectively and return to cervical screening confidently.
I think there are two benefits, or I characterise benefits in two ways. There are advantages for me and there are advantages for the patient, and as a clinician, those are both important. For me, I find it very useful to both make a more accurate diagnosis, but also the localisation of likely change, the ability to identify the best areas to biopsy is very helpful. On the other side, getting a negative Z-scan reading is also quite helpful as a clinician, particularly given the number of patients we're looking to return to routine screening. Having that extra element of confidence it is quite valuable. One always must rely on oneself, obviously, and doing the right things, but the Z-scan helps with that. But also as a clinician, in terms of running the appointment, it's quite useful being able to show the handset to a patient, point out negative results, or point out why we're concerned, what these areas mean. I think helps explain the procedure, and that itself is an advantage for a patient. I think innovation is important and actually underrated in colposcopy. If I think of the colposcopy I'm doing now, kit and what we're looking for and the way we do things is much the same as it was when I started doing colposcopy more years ago than I care to remember. But we are aware of accurate technologies that can improve the acuity of what we do. And we're fools if we don't value that and see that as a benefit. There are areas of research across a number of areas, including those of the outcomes of colposcopy, the outcome of treatment, which show that actually we need to be extremely careful about what we do and how we do it. I don't therefore think that expecting to do the same colposcopy that was being done 10 years ago and expecting better results in a changing clinical landscape is sensible, and therefore we need innovation.
Thank you to Nick and Suzanne. Ladies and gentlemen, can I just remind you to use the chat function if you have any questions, and please send those through. Now we're going to hear from Bradley Quinn on how do we afford innovation in a mature healthcare setting. Bradley is a health economist, and he's going to walk you through a cost impact model that was developed by him at Health Innovation Manchester.
Hi everyone, my name's Bradley Quinn. I'm the Insight and Intelligence Lead at Health Innovation Manchester, which is the academic health science network, the AHSN, for Greater Manchester and East Cheshire. We're one of 15 AHSNs across the country that work primarily to bridge the gap between the NHS and industry and explore how we can enable innovators to develop their solutions to deploy new cost-effective techniques at the front line. I'm going to speak to you for the next 5 minutes or so about the Zilico Z-scan economic model, which you can hopefully see on the screen in front of you now. The model is something we produced last year in collaboration with the Zilico team, but which forms part of an independent evaluation we undertook to support the case for the usage of Z-scan across Greater Manchester. It's a free-to-use tool available for all interested parties that are looking to explore the potential benefits of introducing Z-scan into their clinical pathway. The primary audience is really commissioners and NHS payers. And so at its core, the model adopts a cost-benefit analysis approach, which looks to articulate the cost and potential savings that can arise from deploying Z-scan. Those savings are by and large from deflecting outpatient appointments, with the rationale being that the usage of Z-scan improves clinical confidence, and therefore the suitability of referrals made for see and treat procedures and the number of outpatient follow-up appointments. The model is constructed using data from a range of different robust sources, primarily an independent evaluation undertaken through Oldham CCG that explored the number of outpatient follow-up appointments both before and after the introduction of Z-scan. In addition, the model uses some KC65 data published by NHS Digital on the general makeup of colposcopy referrals and the outcomes at first attendance for patients in order to scale up the findings from the Oldham evaluation to other trusts elsewhere in the country. Finally, the model also incorporates some preliminary data from the Sheffield Sentinel sites, which is to account for the likely impact on service demand of the introduction of primary HPV. So when you open up the model, this is what you'll see. Your version might look slightly different in that a lot of the underlying tabs will be hidden, which is where a lot of the calculations happen. And what we've tried to do is simplify the user interface as much as possible so that users focus only on the parameters that you need to amend to generate the outputs. We've created a generic Z-scan model that acts from the perspective of a typical trust and lets users add their own figures on the left-hand side, and then automatically calculates the potential return on investment on the right-hand side. So the model starts off with the overall number of referrals. You'll see here we've got 1,000, and that's the number of colposcopy referrals that could potentially be impacted by the introduction of Z-scan. After that, the model asks for the number of base units, which we've pre-populated with 2, and then the model automatically calculates the number of disposable heads that are required based on the usual attendance rates for referrals and the unit cost per head. Next, the model asks the user to select one of 2 potential reductions in outpatient attendances, and that's either 24% or 45%, which reflects the upper and the lower threshold from the Oldham evaluation. 24% is more conservative of the 2 estimates, in that it assumes that the deflection of outpatient follow-up from Z-scan is lower than if you were to choose 45%. For the next 3 parameters, I'd strongly recommend against amending any of these unless you've got really clear, compelling local evidence to do so. So the first is the proportion of referrals from primary HPV that will result in a biopsy at first attendance. Here we've used 30%, which is taken from clinical judgment informed by the indicative results from the Sheffield Sentinel sites. The second parameter is asking for the proportion of follow-up appointments arising from first attendance, where that first attendance is a biopsy originating from primary HPV that then results in additional treatment. And when taken in combination, both of those figures provide an estimated prevalence of disease in the primary HPV cohort, which we know to be approximately 9%. The final parameter on this page is the tariff that you'd like to apply, when you can either select the NHS reference cost or the outpatient tariff with the market force factors applied. For anybody not familiar with NHS finance, the key difference between the two is that the tariff reflects what providers will be paid to deliver outpatient appointments, whereas reference costs reflect the total cost of delivering the service in the previous year. And reference costs are often seen as a more accurate reflection of the real resource required to undertake a procedure. So once you've populated those figures, the box on the right-hand side will update with the 5-year net financial position, which in this case is just shy of 288,000. And that represents the overall benefit for the payer once the cost of Z-scan has already been accounted for. Underneath that, the model also includes what the net financial position represents as a proportionate reduction from current expenditure. So you'll see here in this case, that's 10.4% reduction on existing provision. If you click on the plus icon on the left-hand side, you can also see a breakdown of the model outputs on an annual basis. And here you'll see there are 5 key outputs that are generated. The first is the overall number of referrals. So that's the 1,000 and then the growth from primary HPV. The current cost of service, which is without Z-scan. The year-on-year expenditure for Z-scan, which includes base units, replacements, and device heads. There's the proposed cost of the service, including Z-scan. So that's where we account for the reduction in outpatient follow-up appointments. And then the net difference between the two at the bottom. So the sum of the bottom row is what's then used to calculate the 5-year net financial position. There are lots of other underlying tabs where the bulk of the calculations occur, but I won't go into detail into those for now. So that's really the economic model. I hope you found that to be a useful tool, but I definitely encourage you to get hold of the model from the team and have a play around with your own local figures to look at the value for your own local health economy. And do get in touch if you've got any questions. My contact details should be available as part of the WebEx. Thanks for listening. Hope you enjoy the rest of the session.
Thank you, Bradley. Ladies and gentlemen, we've now heard from Nick and Suzanne at Bradford about using ZScan and the benefits it provides. Bradley talking about how we'll afford this. And now we're going to hear from Uma Krishnamurthy at Burnley talking about the route to adoption and the lessons that she learned, and she'd like to share those with you.
My name is Uma Krishnamurthy. I'm the consultant gynecologist at East Lancashire Hospitals and the lead for colposcopy services here. We are a large trust, and there are 2 hospitals under us, the Royal Blackburn Teaching Hospital and the Burnley General Teaching Hospital, with the Women and Newborn Centre here, which is where the colposcopy suites are located. And our colposcopy services serve about 4,000 plus women every year. Half of them are new referrals, and the remaining half are the follow-up appointments. So the ZScan experience at East Lancashire has been a journey that is still ongoing for us. The business case aspect has been different to the evaluation aspect. As clinicians, we are very much used to running the evaluation, adapting, and embracing technology is not something new for us. We always welcome that. And that was not the difficult bit at all, especially having known about the ZScan and being convinced of the positive outcomes, both for the clinician and the patient. That adoption into the clinical setting was absolutely seamless, no problems at all. But when it came to the business case development, the Zilico team have been fantastic. The benefits were very clear. It was health economy-wide financial and efficiency gains that was evident. More than £340,000 over a 3-year period was the gain that was predicted when we put the business case together. But it was the efficiency gains that were most starking, with the ability to reduce the follow-up appointment slots by close to 2,000, nearly 1,860, or as a minimalistic estimate or more. That was what was most attractive for us, because we were already experiencing capacity issues with the increased referrals. We know that the NHS is a very complex organization, and it is the largest employer. And for the right reasons, there are tiers and tiers or layers of governance there, which is meant for the safety and quality to be safeguarded at all times. But sometimes they can also pose not barriers, but they can limit the progress at the pace and rate that we would like to see. So we had to take the business case initially after all the core group discussions and presenting within the colposcopy operational groups. It was submitted to our specialty board, which is for our directorate, and then it had to be taken subsequently to the divisional management board. So it was ratified through both the groups, and then it had to go to the trust level, which was the business review panel. There was a business case review panel, but these meetings don't happen every so often. They're once in every 2 months or whatever, and that delays things as well. Went to one of the trust finance group meetings with the business manager. I went to the previous meetings to move the case forward and to answer any clinically relevant questions. And one of the things we need to remember is the people in the panel, they don't know anything about colposcopy or ZScan. So we have to start every meeting, we have to start from the very beginning, and we shouldn't get tired of doing that. So we are the champions and ambassadors of our services, and we need to promote that every step of the way. And now it has been included within the discussions through the contracting and commissioning group, so that it gets agreed into the commissioning and contracting process. And I'm waiting for that approval to come through. I were to give some tips to my colleagues, I would say first have an awareness that things are not going to be easy and it will take time. Be patient. Start planning the business case well ahead. Use the actual activity figures you have. Even though you will get the NHSI projected figures from Zilico, use the real-time activity figures as well. Make sure you've added the projections to include the increased percentage in new referrals with the primary HPV implementation within the business case, which is crucial. And this is one of those business cases where, in addition to the financial gains, it is efficiency gains that trump. And that is something I came to learn. You have to highlight the efficiency gains with the limitations of the colposcopy, how it can add to the patient experience, how it can reduce the number of punch biopsies with the benefits on pathology pressures, financial gains, patient experience gains, and also release pressures on the colposcopy services itself with reduced biopsy rates. From a 95% biopsy rate, if you were to go to a 25% punch biopsy rate, it will have a significant impact on the administrative side, pressure on the administrative staff, and the likelihood of delays and missed results, which somebody has to chase up. All of that becomes much more easier. So it's efficiency gains that trump although the financial gains are significant. I just wanted to highlight that and just gain an understanding of what the organizational layers are early on, which I didn't do. I learned along the way. So I'm grateful to the Zilico team as well as our trust team for having supported our journey so far.
Thank you to Uma. Ladies and gentlemen, in summary, what we've heard today is that Z-scan really helps in detecting more disease. And if you look at the cohort within See and Treat, then that increased confidence has seen the See and Treat rates go up, performing at a 95% positive predictive value. We've seen the number of biopsies come down because Z-scan helps you direct biopsies more accurately. And then it provides clinicians with the confidence to return women back to routine surveillance and not clog up the secondary care system. And all those clinical benefits equate to an efficient diagnostic within the cervical cancer pathway. And we heard from Bradley Quinn, who developed this independent model to see how these business cases can be supported. Thank you very much for your time. We'll now move into questions that you may have. And I'm going to ask colleague Amanda to share any questions she has for Alison and I to answer.
Hi everyone, it's Amanda here. I've got a couple of questions. The first one that came through is how much extra disease does this device pick up?
Thank you, Amanda. I'll ask Alison to expand on this. But as we saw from the data that I presented, and we've got papers, if you look at overall, we saw a 15% increase in disease detected. You then look at the low-grade cohort, which is the more challenging for clinicians, and we saw a 10% increase from standard colposcopy. Alison?
Yeah, I would agree with you, Samir, in the fact that it's very reassuring from a clinical perspective that you have a device that is enables you to pick out more subtle differences in terms of detecting very small lesions that potentially could be high grade. Sometimes it's very difficult to see those with the naked eye, and I think the ability of the device to be able to more accurately pinpoint directed biopsy helps us as clinicians to be able to visualize much better where we can target where high-grade disease may be. And I think that the device has proven its worth to colposcopists in enabling us to be able to do that. So yes, it is definitely being able to pick up more disease than we can actually see.
Thanks. So the next question that's come through via the chat was, would it be possible to receive a copy of the cost impact model from Bradley Quinn or yourselves?
Absolutely. The whole idea, as Bradley said, is have a look at it, share it. Yes, we will work with you. I think Bradley's advice is also that use your own sort of trust figures. So that means that we have to interact and share that model with you. So the short answer, Amanda, is yes.
Great, thank you. And the last question is, would it be possible to, sorry, I've just said that one, apologies. The last one is, would it be possible to see if this fits into our trust and our service? And if so, how do we do that?
Absolutely. Again, the short answer is yes. How do we do this? So you've got some of the contacts there on the Q&A page, so get in touch with us. How we've done it with the 9 trusts that have already adopted ZScan is we would initially present to the entire colposcopy group, including business managers and finance managers and IT governance. We then, if you're then convinced to go to the next stage, which we traditionally call an evaluation, and that's using it in clinic, and we do a 100-patient evaluation. And we would loan the ZScan device and the sensors, provide all the training, and then help you to collate all that data. And that data, coupled with the global data that we have, together with the cost impact model, would then form part of a business case that you would submit if that's the route you chose to go down.
That's all the questions we've got for now.
Hi, Amanda. I just had a kind of question stroke comment. This is Paul Hanmer from Health Innovation Manchester. First, thanks for a really comprehensive presentation on ZScan from Samir and your team. I can see that a lot of work's gone into that, and I think it really paints a picture of a technology with quite a persuasive evidence base and which is ready for adoption in the healthcare system. So in terms of the next steps, kind of Samir's mentioned the approach if somebody looking at the WebEx today is interested to follow up, or if they're looking at recording rather than the live event. What I was going to ask you was, you'd mentioned the oral application quite early on, and the application of EIS to the oral situation seems very exciting, because it seems to potentially widen the diagnostic pathway for oral cancer. Could you kind of sketch out some initial thoughts of how that could be used and where the development is on that at the moment? Because it seems like EIS could be kind of platform technology in cancers of these kinds.
Paul, thank you very much. Yeah, it's a good question and good observation. The oral cancer pathway has very similar issues to the cervical pathway, in that visualization is used by dentists rather, and oral surgeons. And in order to actually confirm a diagnosis, then having some sort of adjunct or diagnostic tool would add significant benefit, clinical benefit, and clearly, and that relates then to economic benefit. So we've already published proof of concept data on that. We are hoping to go into a study later this year. That might be delayed under the current situation, but at the end of this, we will be in a study, and then that will go into a multi-center trial, and hopefully within the market in about 2 years' time. The concept of EIS, and I think I was talking to someone earlier about this, is that bioelectrics, as it's now being called, there's a lot of interest, and there's growing interest. And there's actually growing investment in this area. Google have recently invested quite significantly in this area. GSK have also invested quite significantly. And I think the coming together of essentially physics, biology, and chemistry, and then being able to handle that data allows bioelectrics to really start to flourish within the healthcare market and provide significant value, whether it be a diagnostic or a monitoring, or perhaps even therapeutic.
Thanks for that, Samir. There's one more question that's come in from Richard on the chat. The question is, apart from the economic model, tool, are there standardized templates that other hospitals can use to assist their adoption?
It's a good question. Again, the short answer is we have templates that we can share, and from centres. What we have found is that every trust actually has its own template, and so, but it can be easily adopted, or we can easily help provide information that would support a business case if that's what one is looking to do. That's it, Amanda?
That's it for now, yeah.
All right, so I think, well, on behalf of Zilico and everyone, thank you very much, everyone who's been on. If you'd like to hear more, please do get in touch. Thank you to Health Innovation Manchester and the AHSNs for hosting this. Good afternoon, and stay safe, everyone.